have got a molecular weight of 30,000 or 40,000 plus, they will leak out of these capillaries into the interstitial space, and they will draw more water from the intravascular compartment into the interstitial space. So in other words, when you have a leaky capillary syndrome, the same colloid, which was your friend, which was known to have an advantage of staying in the intravascular compartment, is now becoming my enemy because it is leaking into the interstitial space and it is drawing water from the intravascular compartment into the interstitial space and making the things worse. And imagine if the same scenario is happening in the lungs, where you're supposed to have an alveolar one membrane and a capillary one membrane, but there is a lot of interstitial edema. This is what we call ARDS. In other words, when you do not know how long a casualty or a patient has been left unresuscitated, and you suspect that they have a leaky capillary syndrome, it's best to avoid colloid and give crystalloid because the risk is less. Although the crystalloid will also leak through the leaky capillary membrane, but because these are smaller molecules like sodium, chloride, with a molecular weight of few hundreds, they are not going to be very big magnets to draw the fluid from the intravascular compartment into the interstitial space. So this is how it is. The other disadvantage of the colloid is that they are more expensive, and the last is that they can sometimes interfere with the interpretation of your coagulation studies, or with the coagulation, or with even the cross-matching. So these are the things which you need to keep in mind. But keep in mind that if you are giving me crystalloid, you have to give me 4 times the crystalloid compared to what has been lost as a blood from a blood volume. So that is the colloid versus crystalloid controversy. Now the other controversy, if you go into the category of crystalloid, is we said there are 2 types of crystalloids which you can give me for the taking care of my deficit, and one of them was normal saline without potassium and without any dextrose. So that is the thing to remember. And the second we talked was a Hartmann solution. So we have 2 categories. One is normal saline or 0.9% saline, they're the same thing, or 1N saline, but there is no KCl and there is no dextrose in that. So that is one fluid, and other is Hartmann's. So what is the difference between these fluids? So normal saline will have 150 or as per old textbooks 154 millimoles of sodium per liter, and same is the chloride. So in other words, normal saline has got around 10 to 12 millimoles of sodium per liter more than what is there in my plasma, which is roughly 137 to 141 or 142. But it has got quite a bit more chloride than my plasma. In other words, theoretically and sometime in practical situation, normal saline resuscitation can produce hyperchloremic acidosis. But that is not a very big problem, and it is very easy to manage. But you should be aware. But one of the advantages of the normal saline is that it does not have any potassium in it. Now compare it with the Hartmann. The electrolyte content of the Hartmann is same as that of your plasma. In other words, the sodium is 131 millimoles per liter. The potassium is 4.5 millimoles per liter. The chloride is 111 millimoles per liter. And then it has got bicarbonate, which is 28 millimoles per liter, out of which 7 to 8 millimoles is contributed by the lactate. That is why the solution is also known as Ringer's lactate and also known as Hartmann's. And plus it has got calcium of roughly 2.5 millimoles per liter. In other words, the concentration of this fluid is same as that of your plasma, but the only disadvantage is the potassium. So imagine if you are giving somebody a 20 ml per kg of push, and that person has got underlying heart condition, or you do not have a facility to monitor the ECG or EKG, depending on where you live, the way you call, then this 4.5 can be a problem. but it will not be a problem if you're not giving massive amount of the fluid. So my take on that is that if you are dealing with a person whose heart status you know, and you have all the facility to monitor the ECG, then you can give heart meds. But if you have none of those things, or you are worried about the cardiac condition, then best is to stick to normal saline, because it does not have any potassium for you to worry. So this is the how you correct the deficit. So that finishes, what fluid to give into each category. Now, if I have to summarize and maybe simplify everything for you, what we have talked and what we taught you is that we know that there are three categories. One was deficit, other was ongoing losses, and the third category was maintenance. If I was a person who is fond of giving crystalloid and is fond of normal saline, then it is very simple. In maintenance, I'm giving you 0.9% saline plus 5% dextrose plus KCl 20 millimoles per liter. So that's my maintenance fluid. It has got sodium, it's got chloride, it's got dextrose, and it's got potassium. If I'm taking care of ongoing losses, then I'm giving you 0.9% saline plus KCl 20 millimoles per liter. In other words, this fluid as compared to that fluid does not have the dextrose. And if I'm giving you the deficit, I'm just giving you 0.9% saline. In other words, this fluid does not have dextrose, does not have potassium. So as you go from deficit to ongoing to the maintenance, the complexity of the fluid increases, and as you come this way, it becomes a simpler fluid. So that finishes the three categories. So you know how to calculate fluid into each category. You know about the importance of bolus of 20 ml per kg. You know that the bolus which you have given, you take it out of the deficit, and then you add the deficit on top of the maintenance fluid, and the ongoing losses are also added on top of the maintenance, and we know how to calculate in each category. And then we know which fluid to give into each category, and we know a little bit about the colloid versus crystalloid controversy, and we can give an intelligent and knowledgeable answer rather than falling into the camps, because we know that there are certain situations where colloids will be better, but certain situations where the crystalloid will be better, especially if you are worried about the leaky capillary syndrome. You do not give colloid. So we'll finish on that.
Thank you for listening to another podcast brought to you by School of Surgery. Remember, you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much, and see you next time. Thank you for listening to another podcast brought to you by School of Surgery. Remember you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much and see you next time.